Present my friend and my buddy from medical school. I've known this face for more than 25 years now. Manu Chakravarthy is an MD, PhD. He's a Chief Medical Officer and Senior Vice President of Clinical Development of Axela Health. Dr. Chakravarthy received his medical degree from the University of Texas Houston Medical School, his doctorate in cell biology and physiology from the University of Texas as well, Graduate School of Biomedical Sciences, and the MD Anderson Cancer Center, and his bachelor degree in liberal arts from St. John's University. He completed his residency in internal medicine at the Hospital of the University of Pennsylvania and clinical fellowship in endocrinology, diabetes, and metabolism at the Barnes Jewish Hospital in St. Louis. Manu undertook postdoctoral research training as an American Diabetes Association postdoctoral fellow at Washington University School of Medicine in St. Louis with Professor Clay Simenkovich, right? Focusing on lipid metabolism. Dr. Chakravarthy was appointed as instructor of medicine in the Department of Endocrinology and Metabolism at Washington University School of Medicine. Manu is board certified in endocrinology, diabetes, and metabolism. Please welcome me. Welcome Manu to the podium.
Wow, that was quite a mouthful, but it's really an honor for me to be here because it's like, kind of in a way coming back home. I live in Boston now, so it's a little bit colder than here, so this is beautiful. Thank you so much for the invite. It's great to be here again post-pandemic because we did this 3 years ago. So good to see a lot of familiar faces, and it's a great venue to sort of really talk about metabolic disease in general. So really excited to be here. So I thought there's a lot of different ways of going about this. In some ways, one of the things that I've been sort of thinking about and studying for a long time is the concept of just fuel homeostasis. How does the body really know, what to choose? We have so many choices ultimately. Do you choose fat over protein? Do you choose, protein over and so on? And so the many choices that the body has to make, it all happens, of course, without you knowing about it, but it's all happening right now. And so that was an area that always fascinated me, even in my graduate research, and then subsequently in my sort of professional career as well. So there's a lot that we can talk about, but one thing I just thought we could focus on today was really the intersection of two really critical organs, which is the liver and the muscle. You heard a lot about how the liver is the orchestrator, so I'll try to give you a little bit more feel for that. And I think there's another organ that a lot of people don't talk about, which I think they should, is skeletal muscle. It is the very important organ that not only provides structure for the body, but it actually is the organ that is the biggest sink for glucose disposal. Without muscle, there's no way you can get rid of glucose. So it's a very important dynamic that I hope you'll appreciate as well. All right, so there was a lot of things about history that was talked about. Dr. Slavin provided a very apt quote from the father of medicine. But here's another one that I sort of kind of try to live by in some ways because I think it's really true. I think we need to really understand the real basis of what is really going on before we know how to treat it. So a physician who fails to enter the body of the patient with the lamp of knowledge and understanding can never really treat diseases. They should first study all factors, including the environment, which I think this is referring to the diet part, which then influences a patient's disease, and then prescribe the treatment. So this actually didn't come from Hippocrates, but it is much older than that. So this was by Charaka, who is sort of considered to be the father of sort of ancient medicine from India, 3rd century BC. So this is fairly old, but it's such a simplistic sort of common sense statement, right? So we really need to understand before you can even start to write your first prescription of what to do. So the point is that there's a lot of underneath that's going on the surface, and our job is to really kind of figure out what that is. And you also heard about the fact that obesity is becoming, well, it's not becoming, it is actually a pandemic. We all have been living through a pandemic, but The forgotten pandemic is the pandemic of obesity. It's been going, on for a long period of time, and the population in general has gotten much fatter, unfortunately. And so when you really kind of, put that into context and say, well, everybody, yes, there's more body fat, but actually, again, going in this theme of going under the surface, if you were to actually take a slice of, an abdominal slice and then see kind of what's really going on there, what you see is that, it's probably hard to see this, but it's actually a CT image of the abdominal axial section. And all of the things that's noted there in red is the skeletal muscle component. Okay, and so you may be wondering, okay, why am I showing this? Because this is in stark contrast to somebody who is healthy, who is, not obese. So a non-obese person, when you look at their muscle mass, it's actually, there's more red you can see, right? So you can quantify all of this and then ultimately come up with what is called the skeletal muscle index. So the normal skeletal muscle index in a male should be, over 52. In females, it's usually over 39. But on the left there, you can see, very pronounced loss of muscle mass. And so this is this is again going back to the theme of really drilling down under what's really going on. A lot of people say, well, you're just fat, but there's more to that. There's also loss of muscle mass as well. And so this interplay between adiposity and skeletal muscle mass is something that has really fascinated me for a long time. And in some ways, I think one of the core underlying drivers, which is a question that as physicians we always ask, is what's driving it. I would posit to you that one of the core underlying drivers for this would be insulin resistance. And again, you'll hear a lot more about it, in the afternoon sessions. Let me introduce that idea now. I'm sure you guys are all familiar with this, but this is one of the fundamental tenets of how fuel homeostasis actually really happens. So before I get into that, just to sort of level set a few things, and so that we're all on the same page. So there is what is called, energy homeostasis. So again, as I said before, the body is smart enough to know how to handle fuel, how to partition fuel, where should it go, etc. And so when everything is working well, when the input is coming in, the fuel, which is fat, carbs, and protein for the most part, is matched with what's going out, which is called the energy output, which is done by exercise usually, or you can have dissipation of heat through sort of what is called a futile cycle. That energy balance keeps everything kind of working well. So that's why it's called energy homeostasis. And then, sorry, sometimes it works, sometimes it doesn't. All right, so when things are stored where they're supposed to be stored, so for example, humans have evolved to store fat in adipocytes. Adipocytes are your fat cells in your body. That's where they're supposed to be stored. So that's kind of what is called as proper energy storage. And when fat sort of gets stored in organs that they're not supposed to be stored in, so for example, if fat gets stored in the liver, you get fatty liver disease, or you get stored in the heart, you get cardiomyopathy. If you get stored in the muscle, you get myosteatosis, which leads to a whole slew of problems. So where it gets stored and how that gets handled is termed sort of metabolic flexibility. So it's the way to properly use the fuel, store it correctly, and that sort of keeps everything, as I said, in a homeostatic balance. Now, of course, the opposite of this is energy dishomeostasis, where things are not working as well. So there's the inability of the body to properly utilize the fuel sources. So fat is not getting stored in the right places, as I said. And then you also have a combination of over energy input, which oftentimes happens because of caloric excess. So people overeat, or you don't exercise as much. So any of those two things can sort of tip the balance and tip the scale towards an energy homeostatic system. So that's really kind of the fundamental basis. I mean, I'm really kind of at a very high level summarizing this, but at a very high level, that's what sort of insulin resistance really is the inability of the body to properly sort of adequately respond to the most important hormone, which is associated with fuel homeostasis, which is insulin. And that will, ultimately be, initially precipitated with hyperinsulinemia. And you'll hear a lot about it from Dr. Slayman's lecture. So I won't go too deep into that, but to suffice to say, the three kind of key orchestrator, organs is the fat cells, which is where you're supposed to store fat, and of course the muscle, and then the liver, which is really the key factory, if you will, that sort of coordinates everything. So when things are working well, fat gets stored in the adipocyte. The muscle is designed for carbohydrate oxidation, so glucose is burnt, and then the liver is able to convert free fatty acids and then eventually store that or move that into glucose. And then, of course, when you have hyperinsulinemia, which then leads to this phenomenon of insulin resistance, the inability of the body to respond properly, then you have all of the actions of insulin resistance, which is now, instead of storing fat, you actually have increased lipolysis. So meaning, this is a breakdown of the stored triglycerides into free fatty acids, and then you spill out a lot of free fatty acids into the bloodstream. You have decrease in fat oxidation, which then leads to in accumulation of fat in muscle, which, as I said, is not a good place to store fat. You decrease the oxidation of glucose, so the inability of the muscle to burn glucose. And then in the liver, now you're starting to actually have enhanced de novo lipogenesis, a fancy way of saying more fat synthesis. So now, fat again, is not supposed to be stored in the liver. And so you have this increase in triglycerides in the liver, which ultimately can lead to fatty liver disease. And so all of these things ultimately are the reasons why we have what we call sort of the plethora of maladies that we have. And insulin resistance is ultimately the driver of all these different things. So, we talked a little bit about how testosterone impacts the heart and the vasculature. The underlying driver for that is likely insulin resistance, which is really driving all of that. So, that leads to heart disease. We'll talk a little bit more specifically about liver here. Certainly type 2 diabetes, kidney disease that Pete introduced you to. So this is sort of in some ways, if you were to sort of take a very sort of simplistic, reductive view of what is the underlying driver of many chronic illnesses, it's the inability of the body to properly store and handle fuel. And the reason why the body cannot do that is largely because of insulin resistance. So, so what, in the rest of this talk I can focus a little bit on, again, we can spend days talking about each one of them, but really, in some ways, just to kind of give you this flavor of the muscle-liver, crosstalk interaction, I'll just focus my talk today a little bit more on the interplay of fat in the liver. And so this is termed as non-alcoholic fatty liver disease. As the name suggests, it's not alcohol-driven. And alcohol is, of course, the most common form of liver disease, of course, in the country and the world in general. But increasingly, we're starting to see many cases of non-alcoholic liver disease because of this, obesity and diabetes pandemic. The remarkable thing about, from a phenomenon standpoint, why NAFLD is so interesting is because you actually see hyperinsulinemia even in people that are lean and have normal glucose tolerance. So this is, one of the most sort of the interesting conundrums, because a lot of people have attributed NAFLD to be only seen in obesity. But as it turns out, when you actually sample the blood of people with NAFLD, even if they're lean and seemingly of normal glucose tolerance, they actually have hyperinsulinemia. So this is, again, yet another proof that it's the hyperinsulinism, insulin resistance that's driving this disease. So why do we really care about this, right? Why one should bother with this? It's because ultimately, if you actually have fatty liver disease, it impacts your daily functioning. And we're not talking about like higher order functioning or anything. It's just like basic things. Can you walk stairs, or can you just actually even walk? Can you prevent falls? Because falls is a big problem, right? So basic sort of daily actions of the day get impacted just because you're carrying fat in the liver, an organ where you're not supposed to store fat. So this was a study that was done in the UK Biobank, which is a very large database in the National Health Service of the United Kingdom. And there, because it's the NHS, they have very good records of where people's sort of longitudinal data can be followed over a period of time. And so basically when they looked at that, and this was a very small, relatively small sample, for about 1,000 people, mean age in the 60s, the mean BMI was around 30, and they looked at whether they had fatty liver disease or not, which is defined as a fat fraction of over 5%. So if you carry more than 5% of fat in your liver, that's considered fatty liver disease. And then they compared it to those that didn't have that, and you can see those that actually have accumulation of fat in the liver, have a much higher propensity for the inability to walk, the inability to climb stairs, increased propensity for falls. And so this tells us that, it's just not just, well, I just have a little bit of fat in the liver. It's really a burden on normal daily functioning. Then these investigators went a little bit further, which was really interesting, from a sort of, mechanistic understanding perspective, where they actually now looked at not just overall fat per se, but in the liver, but also in the muscle. So fat composition in the muscle and how that it sort of really translates to the fat composition in the liver. And so they came up with this sort of grid where you can actually look at both the volume, which is sort of the muscle, the total, the mass of fat, the mass of the muscle, as well as how much fat was in the muscle. And so they kind of divided that up into sort of those four quadrants in a way, where you can have low volume of the muscle, or a high volume of the muscle, or low volume of the fat and a high volume of the fat. And so when you did that, you kind of have people that fall into these four categories. So there were people that had what is considered as normal composition, which is good muscle mass, no fat. Again, remember that you're not supposed to store fat in the muscle. You can have only high muscle fat, with a high, high muscle volume. And then this one was sort of the worst in some ways, where you had low volume of the muscle, but also a very high amount of fat in the liver, in the muscle. So this is considered as adverse muscle composition. And they asked the question, what happens to those people? So if you just looked at the people that just had low muscle mass, okay, so remember in the previous slide I showed you what happens when you have a high amount of fat in the liver. And here, if you actually had low muscle volume, you have a very similar propensity for the lack of ability to conduct your normal daily life. So the grip strength is low, walking pace is low, you have more falls. So definitely, either fat in the liver or low muscle volume, leads to these, kind of issues. But now if you actually have, high fat in the muscle, things get much worse. So these are people that have both, high liver fat and high muscle fat. So now you're really kind of having a double whammy effect, if you will, where you're really compounding the functional disability versus either one alone. And so this clearly tells us that there's something that is going on between the interaction between the liver and the muscle that speaks to each other, and then you have this compounding of effect on basic functions of life. Okay, so the inability to walk or having more falls is, again, I hope that you all agree, is not a trivial thing, right? I mean, these are things basic that everybody needs to do. So this type of data really then put the idea of what is called the muscle-liver crosstalk on the map, and then we published a review a couple of years ago, sort of really summarizing all of this, and ultimately came to this conclusion that when you actually carry fat in organs that you're not supposed to, like in the liver or muscle, not only does it affect the basic functions, but you also have a much higher risk for type 2 diabetes, cardiovascular disease, specifically for MIs. So these are now becoming much more serious, right? So it's not just a triviality of simply saying, well, you have a little bit of fat in your liver or a little bit of fat in your muscle. These lead to major consequences that ultimately decline your quality of life, and to very significant comorbid conditions that further compound things. So all of this then ultimately kind of begs the question of would it matter if we actually improved liver fat? Would it actually help in terms of decreasing these sort of comorbidities and these burdens? And again, without going into every little detail, I can tell you that there have been studies that have been published, including our own, which shows that as you increase your muscle mass, okay, again measured through the skeletal muscle index, you can actually basically decrease the likelihood of, or increase the likelihood, I should say in this case, of NAFLD resolution. So in other words, you can actually get rid of your liver fat purely by increasing your muscle mass. So go to the gym and exercise and do weight training, it actually helps with your liver fat. Quite remarkably, it also decreases the overall incidence of NAFLD itself. So incidence is the new cases of the disease. Okay, it's not the prevalence, which means the existing cases of disease. So just by improving your muscle mass, you can actually decrease the incidence of new disease by 30%. So that's a huge, kind of a significant impact that you can have in terms of how much benefit one can have by simply just having better, healthy muscle dynamics. So again, because of all of these interactions and relationships, right? So between the fact that having more muscle and liver fat, leads to these kinds of diseases, and the fact that you have potential improvements just by improving one of these compartments, it leads to the question of how is this actually happening from a mechanistic level. So in the next couple of slides, I'm going to try to give you, as best as I can, in a very simplistic way, this sort of summary, of the literature, which is, pretty extensive, and just can tell you that there are many factors that have been identified, some of which you heard from Pete, such as inflammation, oxidative stress. The same kinds of things certainly predispose for this as well. But of course, one of the most important one is, as I've introduced you to, is insulin resistance. And we'll share a little bit more about how does insulin resistance really actually go about doing this. And then one of the core sort of features of this is this idea of metabolic inflexibility. So again, coming back to this concept of fuel dyshomeostasis as sort of the key link between the liver and the muscle. So this is sort of a little bit of a build slide, so I'll kind of build it out for you and to sort of see how this actually all interplays now, introducing you to more of these players, if you will. So we talked about the fact that when insulin's working well, you store the fat inside the fat cells, and ultimately you have increase in glucose oxidation. But when you have a substrate overload, that comes from again caloric excess or lack of physical activity, you end up with insulin resistance, and insulin resistance will decrease the burning of fat, certainly decrease the burning of glucose, starts to accumulate fat in the muscle. You have increased lipolysis, as we talked about, and then ultimately, leading to this sort of increase in fat and other lipid droplets in the liver. So we talked about that. Now, mechanistically, what we've shown is that the reason why fat accumulates in the liver is through basic sort of interconnected interplay between not only insulin resistance, but there are also these circulating factors called myokines. Myokines are sort of things that are secreted by the muscle, like myostatin, IL-6. You've heard about IL-1 beta, but IL-6 is a very specific myokine or a cytokine within the muscle. Those start to talk to the hepatokines, which are these circulating factors that are actually released from the fatty liver. Things like FGF21 and a whole bunch of other things which I won't bore you with. But essentially, these sort of interactions now start to kind of communicate, through the bloodstream by pouring out pro-inflammatory and pro-cytokine sort of factors, and then they turn on important what are called transcription factors. And transcription factors are factors that sort of change your gene programming. They basically signal how the genes get transcribed, what genes get turned on, what genes get turned off. And then, to make the long story short, there are lots of transcription factors that actually control fat, production, fat oxidation, and then and essentially the end result is a very dynamic interaction between each of these organ systems, leading to fatty liver disease, which progresses from just fat accumulation, and then fat inflammation, which is called NASH, and then ultimately, as the liver sort of really gets progressed that fat now starts to convert to fibrosis. And so when you get liver fibrosis, and that's, you end up with a situation called cirrhosis. And cirrhosis is a pretty severe condition of the liver, and many of the treatments right now actually don't really work there. So the only treatment for liver cirrhosis at this point is a liver transplant, which is not easy to do. So yeah, there's a lot of information here, obviously, but the key takeaway is in some ways the fact that there's a very close and dynamic interplay between each of these organ systems, and in particular, how the liver and the muscle talk to each other, and the fact that the underlying driver of that interaction is insulin resistance. So in terms of kind of where we need to go next, I think these are the exciting times for this field, because now we actually have a lot of tools that we can bring to bear. We have the real world data from things like the UK Biobank. We have excellent sort of bioinformatics through deep sort of sequencing of genes, and really getting a really good handle on all the metabolites. And so I think it allows for now getting to a much deeper understanding of the biology, which we didn't really have before. So I think it's safe to say that we've established a good link between insulin resistance and these chronic diseases. Now the question is, what is the actual mechanism? How does this actually work? I think one of the easy things that we can do in our practice is to incorporate, evaluation of muscle mass and function in our daily sort of evaluation. So we always have a weighing scale, right? So everybody gets a body weight and height and BMI. But you can actually, start to think about incorporating muscle function assessments, and they're easy to do. And I don't have this in the slide, but it can be as simple as measuring a hand grip strength. There's a little hand grip meter that you can get. You can have them do a chair stand. So you can have your patient sit and then try to get up 5 times. So there's a timed chair stand assessment. You can actually have them walk and measure their gait speed. So these are all things that can be done relatively easily, and hopefully, as I've shown you, understanding muscle function and muscle mass makes a huge impact in their metabolic outcome, because you can give them all the drugs you want, for their diabetes, and their liver disease, but if their muscle mass is not, there, or the muscle function is not there, you're not really doing a good service. And then ultimately, yeah, I mean, I think this is another huge area, and this is why I think many of us are here, because we're all very interested and excited about how do we bring sort of dietary and lifestyle approaches to very complex, very difficult to treat diseases, right? As I've shown you in the previous slide, and I made that purposefully complex because it is, there's so many interactions, so many compensatory mechanisms. It's very hard to imagine that a single drug can really address all of them. And so in some ways, it goes back to Hippocrates or to Chakra and says, look, food is the medicine at the end of the day, or lifestyle is the medicine at the end of the day, and then how do you deploy that in the most sort of scientifically rigorous and patient, sort of appropriate way. So I think that's an area that I think is ripe for a great progress, and again, some of us are here for that reason. And then ultimately, we do need to conduct proper trials, right? So, and this is, maybe a philosophical debate to have, because some people might say, well, if I'm giving this to my patient and it works, it works. I don't really care whether it works in a trial or not. But if you really want to adopt this into a much bigger societal, public health kind of framework, I think, people tend to, at least as physician scientists and other physicians, might want to see some evidence that this is actually working. So this is another area that can be hugely ripe for progress. Because again, we have the tools, we have the right science. Now we need to do the right trials to try and see in a controlled setting, do these things actually work, for our patients? And if it does, then many of the interventions that we're talking about, either through a keto diet or through lifestyle interventions or exercise, these can then become part of the guidelines, because they're not currently part of the guidelines for that reason. So I think there's a lot of questions, that we need to sort of try to address. But ultimately, I do believe that, we can understand them, if we can, just kind of figure out, what they are. That's the whole point of this, right? Is to try to discover underneath the surface, what is really actually happening. So really, thank you for your attention, and happy to take questions.